Hello, and welcome to Evaluate and Treat Dysfunction of the Lower Limbs using Diagnostic Motion Evaluation and Arms Release Technique. This is Lesson 1, and I'm Deborah Getz. I'm the physical therapist and the creator of this program. If you look at the right of your screen, you can find my contact information. My email is physicaltherapy@hotmail.com, and by phone I can be reached at area code 646-221-5293. Please do not hesitate to contact me via email or phone should you have any questions concerning this lesson or any of the future lessons that we will be presenting. We'll begin with definitions. To justify what we're doing, we need to define the following. The first is connective tissue, and connective tissue is the most diverse tissue of the human body. It has a variety of functions, including the storage of energy, protection of organs. It provides the structural framework for the body. So if we took all the bones away, we would still have a framework of our skeletal system due to connective tissue. It connects body tissues together and to other parts, and epithelial tissue to muscle tissue. Here are some examples of connective tissue: fascia, bone and cartilage, fat, ligaments and tendons, and blood. Notice here that there's not nerves mentioned here, and nerves are not examples of connective tissue. However, the tissue surrounding the nerves is considered to be connective tissue as well. When we look at fascia, which is a type of connective tissue, in vertebrates, fascia is the most common type of connective tissue. It holds the organs in place, separates muscles, and attaches epithelial tissue to underlying tissues. And it's made up of 3 different types of fibers. We have collagenous fibers that are made up of collagen and consist of bundles of fibrils that are coils of collagen molecules, and it's the main protein in the connective tissue. We have elastic fibers that are made of elastin, and these are stretchable and malleable. These will be important for us with the work that we're going to be doing. And lastly, the retinacular fibers, which join connective tissue to other tissues, the connection, so to speak, the connection of connective tissue. When we use the term myofascial, it's the type of fibrous connective tissue that encloses and separates the layers of muscles. So there are 3 types of myofascial tissue. The first is the endomyosin, which surrounds the individual muscle fiber. And then the perimyosin, which is a group of fibers that are surrounded by connective tissue called perimyosin. And lastly, the epimyosin, which surrounds the entire muscle. So when we're palpating myofascia, we're not really certain whether we're palpating the endomyosin, the perimyosin, or the epimyosin. In fact, it really doesn't quite matter because, again, these types of fascia contain the elastin, which is malleable, and we will be able to move the connective tissue, the myofascia, in a way to alter the structure of this type of connective tissue. In this class, we're going to talk about structural dysfunctions. Structural dysfunctions is a dysfunction of the connective tissue, and in the human being, it will cause pain or inhibit efficient movement. Structural dysfunctions are going to be those that we will be focusing on to release or create movement within the myofascial and other types of connective tissue that we will be mobilizing with the arms technique. Implications for therapy based upon what we've just learned is that movement of connective tissue is imperative to motion of the system and shock absorption. We often forget about the importance of shock absorption, the ability of the human body to tolerate the forces that are acting on it during activities of daily living, activities such as running or walking. All connective tissue should have movement within it, and that is where we come up with the term a springy end feel. So all connective tissues should move and have a springy end feel. They should not be hard or rigid. We need to note that connective tissue is interconnected like a web. As a result of this, dysfunction in one area of connective tissue can and will affect another. So we need to keep in mind that dysfunction might not be, and often is not, at the location of pain. That connective tissue, let's say, affecting a shoulder that is dysfunctional could be located in the forearm, for example. And lastly, connective tissue shapes the entire structure of the body and can be impacted by the forces acting on it, including release. And this is how we make an impact. And this is illustrated in Wolff's Law. There are 42 diseases that affect the subtype of connective tissue, fascia, ranging from autoimmune diseases including rheumatoid arthritis, genetic diseases like Marfan syndrome, infectious diseases like cellulitis, and orthopedic conditions including sprains, strains, and plantar fasciitis. There are some primary factors that can affect the repair of connective tissue and the repair of collagen, which is a primary component of connective tissue. And they are your age, so the younger you are, the faster you can repair connective tissue. Circulation, and this is where we would come in as therapists by implementing modalities and mobilization that can facilitate circulation. Nutrition, there's diet and supplementation that can be taken to impact the repair of connective tissue, and we will provide you with that list. Prevention of re-injuries and inflammation by changing the forces that acting on the body to promote healing and alleviate stress to a region. If damage has been done to an area, we cannot change what has been done. But what we can change are the forces acting on that area that had caused the damage to begin with. And that is the impact that we will have using the arms release technique and the diagnostic motion evaluation to show us exactly what forces are acting on an area. Now, when we do our evaluation, it's going to be important to think about the following. First of all, when we talk about our subjective history, what we need to find out is what activity, position is causing a patient's pain. You need to ask your patient specifically, what activity do you have difficulty doing or causes your pain? Secondly, we'll need to look at the past medical history, specifically looking at a history of trauma, disease, surgery, or anything else that has caused inflammation. And we will speak about the importance of inflammation a little bit later on. We'll look at the posture, alignment, and structure. And there's a saying that structure dictates function. And the reason that structure dictates function is due to the length-tension ratio, which states that a muscle will contract with greatest vigor when it is at a certain length. Since muscles attach to bone, a problem with alignment or an alteration of alignment will render the muscle inefficient. We'll do goniometric measurements, and this is where diagnostic motion evaluation will come in, assessing not only the measurement of range of motion, but the quality of the range of motion to be achieved by a patient. What we will often see, particularly in people with disease or dysfunction, is that they will compensate for a lack of motion by utilizing a different area of their body to compensate for that motion. And lastly, we'll look at strength via manual muscle testing and stability testing, which can also tell us quite a bit about what's going on in a person's body. And for this class, we're going to be focusing on 1 through 4 primarily. So what is diagnostic motion evaluation? It is a system that uses active and passive range of motion to determine why a person cannot do an activity or achieve motion. It also allows the therapist to identify whether a motion deficit is due to a structural or a non-structural dysfunction. We had mentioned structural dysfunctions earlier. They are dysfunctions of the connective tissue in the body that are anatomical blocks to motion and to quality motion. And when we're evaluating motion, we will need to look at both passive and active range of motion. We can measure them goniometrically for our objective measurements as well. But when we're doing diagnostic motion evaluation, it is important to note whether the quality and the characteristics of the passive and active range of motion are the same or different. So if the passive and active range of motion is the same with regard to quality and compensations, then there is a structural dysfunction. So whether the person is moving volitionally or if they are being moved passively, if there is a structural dysfunction, it will always be there. Why? Because it's a thing. It's an anatomical structure blocking or inhibiting quality range of motion. And it will need to be released. That is the only way to get rid of it. If passive range of motion is significantly different than active range of motion, then it is a non-structural dysfunction. There is another reason other than an anatomical thing blocking that range of motion. A reason that someone might have a non-structural dysfunction could be paralysis. And our treatment will be different. It will not include release, but it will be a different type of treatment to try to restore quality range of motion. And in this class, we will be focusing on treating the structural dysfunctions. Here are important things to keep in mind for reasons of non-structural dysfunctions. And I've come up with these. There's probably more, but so far this is what I've come up with. First, inflammation or trauma. And the reason why someone could have a non-structural dysfunction due to inflammation is that for every cubic centimeter of inflammation, a muscle shuts down by 1%. This is important to note because typically inflammation, very much so chronically, will occur at the joints. And the muscles that are closest to the joints are our core muscles, which are responsible for stabilization of a joint to allow the movers of the joint, the moving muscles, to achieve motion. If our core muscles are shut down, there will not be stability. And as we know, as therapists, we have learned that you need to have stability in order to have mobility. So an individual with osteoarthritis of the hip, they might lack range of motion because they lack stability due to the inflammation that's occurring at their hip joint, inhibiting their core muscles. And this is often why we can achieve range of motion but not get carryover, because we never addressed the core muscle or the stability component of that individual's lack of range of motion. And through diagnostic motion evaluation, we'll be able to determine whether that person has a anatomical blocking, which is a structural dysfunction, or perhaps a non-structural dysfunction, meaning that inflammation is occurring in the joint, which is preventing motion from happening. The next is alignment, and I said structure dictates function. I'll change that to alignment dictates function. And again, this is due to the length tension ratio that states that a muscle will contract with greatest vigor when it's at a particular length. So alterations in the skeleton, things like bunions or deforming arthritis or forward head rounded shoulder posture, will alter the ability of the muscles that are affected at those particular anatomical structures or bones of the skeleton, will not be working as efficiently as they would when there would be a normal alignment, a functional alignment within the system. Next, we come to upper motor neuron disease or injury, and these include stroke, Parkinson's disease, dementia, TBI, MS, diseases affecting the brain that can impact quality of motion. And we also have lower motor neuron disease or injury like radiculopathy, neuropathy, nerve compression, those kinds of things, severed nerve that will inhibit motion and quality of motion from occurring, but not due to a structural dysfunction, a structural block. Then there's severe atrophy, so individuals who've been in a coma or in outer space where immobility is due to inactivity and muscular atrophy. And lastly, psychological. So fear of movement would be a possibility of a reason why someone would not be able to move a body part or have pain with movement because of a non-structural dysfunction. And all of these will be in the patient's past medical history with the exception of alignment. And we will assess alignment during our initial evaluation when we look at posture and alignment. So it will oftentimes be glaring to us when somebody has a postural malalignment. And again, the other factors should be in the past medical history, and you should also ask your patient about diseases or injuries that may have caused inflammation or trauma, even if they occurred years ago. Because if those core muscles were never facilitated to be restored, they oftentimes will still be unstable in a particular area, even years after somebody has sustained an injury or trauma. So, what is diagnostic motion evaluation? It tells a therapist where, that means the location, and whether something is a structural or a non structural dysfunction. And basically, it tells us where and what we need to treat. Where and what we need to treat. Because as I had mentioned earlier, if someone has a non-structural dysfunction, the treatment is going to be very different than the structural dysfunction. With a structural dysfunction, we will need to mobilize. With a non-structural dysfunction, we might need to stabilize because of the inflammation factor shutting down the core muscles, which are stabilizers. When we're doing diagnostic motion evaluation, the therapist will utilize their senses during various body motions by the patient to determine where and why a dysfunction is occurring in your patient. The principles of diagnostic motion evaluation include the following. When a person is performing an ADL, or active or passive range of motion, the therapist needs to observe where the motion lacks fluidity. That means that motion should be initiated at a particular point, and that motion should be fluid and sequential through each anatomical structure, from where the motion is initiated to where it ends. So I like thinking about a stack of dominoes. And in this picture, we have 8 dominoes. And after domino 1 falls, then domino 2, 3, 4, 5, 6, 7, and 8. And that is the same type of fluid motion that should occur in our body. We, I think, are taught this when we're looking to evaluate the spine, the vertebra of the spine. We want to see movement through each vertebra sequentially. We don't want to see movement occurring at, let's say, cervical level 2 and then moving right to cervical level 7. We've not moved through 2, 3, 4, 5, 6. So what is going to happen is probably hypermobility at cervical level 7 because 2, 3, 4, 5, and 6 are not moving. And hypermobility will cause irritation and inflammation. So that area would not need to be mobilized. What would need to be mobilized are cervical levels 2, 3, 4, 5, and 6. And cervical level 7 would in fact need to be stabilized, because it has become hypermobile by compensating for a lack of motion through the cervical spine levels 2 through 6. The second principle is looking at range of motion and seeing where there is a compensation for that range of motion. So when we look at the picture to the right, we'll notice that the patient has dysfunctional range of motion in his left arm. And what we'll see is a winging of his left scapula. Okay, down at the inferior angle, you will see it moving laterally. We also notice a lot of wrinkles at the glenohumeral joint and around the traps on the left shoulder. But what we don't see is movement in the humerus on his left arm. If you notice right around the elbow and maybe even before the elbow, it seems like this individual has difficulty moving into flexion at this particular area. And in fact, there's a place right here. I would almost suspect that this individual has had a humeral fracture at some point in his life that has some structural dysfunctions that are inhibiting his ability to flex his left shoulder. So at the point where the motion becomes compensated for this individual, it would be the point with which his traps would start to fire, or his scapula would become winged, or perhaps his glenohumeral joint will become elevated. Common compensations for shoulder flexion. We see them all the time in our patients. Using diagnostic motion evaluation, the principle states at the point that the compensation occurs is the location of the dysfunctional tissue. And when we move that tissue passively, we would want to see if the compensation still occurs or not. And if it does, then it is a structural dysfunction. It will need to be released. So in this individual, what I would do is I would stabilize this glenohumeral joint that is hypermobile, and I would mobilize this area of the humerus just above his elbow to facilitate quality flexion of the humerus, so compensation does not need to occur at the glenohumeral joint and the scapula. The second principle is when we're looking at open and closed chain motion. Because when we look at open and closed chain motion, our observation and our palpation will occur at different locations. For open chain motion, the observation of the motion will be distal to proximal, meaning that you will begin your observation at the most distal joints that share muscle attachments for the action being performed. So in this picture, we're looking at dorsiflexion, and this is open chain dorsiflexion, and the motion is occurring typically, we believe, at the ankle. And what we see is that there are muscles or structures of the toes that also cross the ankle. So we will begin our observation at the toes. And when we look at this individual, what we will see is that the toes really have no problem moving in toward dorsiflexion. Okay, in fact, they are compensating for the motion. And what we see here is that there's some knee bending on the left leg. And what I would say is that depending on when that knee started to bend, that would be the location of the dysfunction. So it looks to be that this person's structural or non-structural dysfunctions begin right at the metatarsals, because he is able to bring the toes back in toward the direction of dorsiflexion. However, the metatarsals are not lifting in the direction of dorsiflexion, and he is compensating by bending his knee. So in this individual, I would stabilize his knee, which is the area where he compensates, and mobilize if this is a structural dysfunction. And the way that we would determine that is through passive range of motion and palpation. So I would take this individual and I would palpate each metatarsal head, the distal part of the metatarsal, and determine which area does not move, mobilize there and stabilize at his knee, and we should see an improved active range of motion occurring in dorsiflexion without compensation at the knee. For closed chain activity, the motion begins proximal to distal, beginning at the most proximal joint that shares a muscle attachment for the action being performed. And in this individual, if we looked at dorsiflexion again, dorsiflexion, the most proximal place that a muscle attachment is that shares the ankle would be at the knee. The gastroc crosses the knee joint posteriorly and attaches to the femoral condyles. So in this case, we would begin our observation and palpation at the knee. Meaning, does the upper tibia come forward into dorsiflexion, followed by the middle of the tibia and fibula, I should say, down to the ankle, and then through the toes. And if we look at these pictures that are in front of us, when we look at the picture when we're facing the screen to the left, we notice that this person is actually compensating for a lack of ability to squat by externally rotating his hips. So he probably lacks lacks flexion of the hips and external rotation of the foot and ankle. Again, telling me that he likely lacks dorsiflexion at the foot and ankle. Versus the picture on the right, where this individual has no difficulty coming down into a full squat. He has beautiful dorsiflexion at the foot and ankle, allowing him to come down into a full squat without compensation. Now, looking at this, we don't know whether this is a structural or a non-structural dysfunction because we need to look at passive range of motion. These are both in the pictures active, as most of the pictures have been. Moving on, the therapist will use a combination of visual, tactile, and verbal skills, meaning we will observe quality, range of motion, and compensation. We can also feel for compensation. So if we see, let's say, the shoulder elevating with flexion, we can place our hands on the shoulder and move the arm in passive range of motion. And at the point that we feel the motion occurring at the shoulder, we could say that that's where the compensation occurs. Or we can do passive range of motion and feel resistance. Now, we've all felt resistance to passive range of motion, particularly in the other example where I would be palpating the metatarsal heads. I would palpate them and try to push them in the direction of dorsiflexion and feel for resistance. So feeling for resistance would be another way to use the diagnostic motion evaluation principles. And lastly, we're going to use our verbal skills, communication with our patient, particularly when you're beginning using diagnostic motion evaluation and the arms release technique. It is going to be vital to communicate with your patient. And if the patient has good body awareness, you can articulate to them, or they can articulate to you, at what point does the motion become difficult to perform? At what point does the motion become resistive or challenging to achieve? Awkward would be another adjective to use to your patient when communicating with them to determine the location of the resistance, of the dysfunction. And again, when we look at active versus passive range of motion, it will tell us whether or not there is a structural dysfunction or a non-structural dysfunction. Again, a structural dysfunction is an anatomical structure, connective tissue usually, that is physically preventing movement or preventing quality of movement. It is a block, it is a wall, and the only way to get through that wall is through mobilization. A non-structural dysfunction could be one of the other factors that I mentioned earlier. And in that case, we would need to address those situations and treat accordingly in order to achieve quality range of motion. So again, the treatment will be very different when we have a structural versus a non-structural dysfunction. And again, this is why diagnostic motion evaluation is vital to efficient treatment and successful treatment of our patient with good carryover. I mentioned the senses used in diagnostic motion evaluation in the arms technique. So just to review, visual, when we're observing quality range of motion and compensations. Tactile can be used for passive range of motion. And also, as I mentioned before, if you notice the area of compensation, you can place your hand there and determine if and when movement occurs. And also feeling for the point in range of motion where there's resistance or compensation in the system. And lastly, verbal communication with your patient, asking your patient at what point does the motion become difficult to perform.